Yeah.
Okay, it's 2:00, so I am going to call the Winnebago County Community Mental Health Board meeting to order on October 5th, 2022. Roll call, Dick Cooner,
Present.
Dr. Bill Gorski, Wendy Larson, Bennett,
Still here.
Reverend Copeland, Dr. Giardini,
Here.
Tim Neighbors, and Linda Sandquist. Unfortunately, this meeting will not have a quorum, but we will be listening to the presentation. So just falls that way sometimes when members cannot miss what's going on in their real work life. So the rest of us are here and very excited to hear your presentations. I'd like to also welcome Jason Holcomb and Chelsea. And we have a new employee for R1. Would you like to just introduce yourself too?
Sure. Yes, my name is Nicole Bennett. I'm a social worker, and born and raised in Rockford, Illinois.
Welcome aboard. We're happy to have you. We have not had any requests for public comment today, so we can quickly move into the presentations. And first up is the City of Rockford, the mobile integrated health and the mental health program, and we have the chief present. And we are delighted that you took the time personally to come and speak with the mental health board.
Absolutely. Thank you for calling.
And
I'm just gonna sit here in case the chief needs me to.
in case you.
No, wait. Is there,
You can just give me the cue. on
do you need the cue?
Yeah.
Okay, here, I'm gonna go like this too, because there's a little bit of a glare. That way I'll know if I can
That's
get you
wonderful.
through. So is everybody okay? Everybody can see it? We're good?
It's live.
Okay,
so-
so first of all, thank you for allowing me to be here today and to just kind of give you an overview of the program that we have put together, and we are so excited and hopeful with regard to the holistic approach that the city of Rockford and the Rockford Fire Department are taking with the mobile integrated health mental health manager. So without further ado, so who we are. Currently, we have a mobile integrated health program. So we have 2 mobile integrated health managers that are on staff. And they partner with UW Health and a nurse from UW Health. And they work with patients that have been either assigned to us through Swedish American, or they have been referred to the program from our first responders. So currently there are the 2 paths to get into our mobile integrated health program. That focuses on the ability to connect people with long-term illness to services. So the behavioral health piece was not the initial, when we initially launched the program. It was to address folks that have continuous ED visits, continuous admissions to hospitals, because they aren't compliant with medications, aren't compliant with treatment, don't have access or don't know what the access to services are. So that's what our current mobile integrated health program is. In 2020, we ran a pilot for 6 months in partnership with Swedish American, UW Health. And we did see a significant reduction in our emergency room visits, as well as our Center for Mental Health visits. So you'll see some numbers on that a little bit further in, but that program was run for, like I said, 6 months, and the focus of that program was solely on patients that fit that criteria that needed mental health response or behavioral health response. Huge, perfect. So who we serve: patients in acute mental health crisis, patients who used 911 or the emergency department frequently for mental health care because they don't have anything else or aren't aware of anything else in a crisis that they can access, right? So patients transitioning from inpatient mental health care to home, and then patients who are at risk for overdose. So what we want and what we have presented to the board, and I have this, can I move this out of the way here because I'm a big nerd and it's my hand, so, all right. So the reason I have this graphic here is because this truly is a holistic program. So we are trying to address the mental health crisis in our community through a number of ways, right? So initially, we've got all the different pieces, and for those of you who were there on the tour, I know you were there the other day.
Dr. Gorski.
Yep, Dr. Gorski was there. So some of you were able to see some of these pieces, namely the 911 Pro QA, our software, if you will, that we have, we are in the process of implementing. What that does, that truly is the piece that kind of gets us all the other pieces, if you will. That 911 Pro QA brings us into this century in terms of our ability to talk to folks when they call in at the public safety answering point. So they call in a 911 and it provides our telecommunicators with a path to follow. And there's a protocol specific to mental health crisis, protocol 41. You'll hear me mention that a little bit further on. And it walks our telecommunicators right through how to deal with that caller. And while they're doing that, they're also working through that. Is this an emergent call? Is this something that needs EMS, fire, law enforcement, or is this something that is strictly behavioral health? And do we have a service that's more appropriate to send for that person? Right? So that's kind of the very, very basic piece of it. As it starts at the very beginning with the call that comes into the 911 center. So the protocol 41 is the main piece for the behavioral health component. Once we have our Pro QA, the software that I just mentioned up and running, that also allows us to start to triage our calls. So currently we can give pre-arrival instructions to folks, but we literally do it from a small slide deck, if you will, or a large Rolodex. It is a metal bracket with cards in there, and our dispatchers flip back and forth. And as they're flipping back and forth, they are giving, locating the appropriate card, and they're giving pre-arrival instructions. The Pro QA software eliminates that. It's all integrated into our computer-aided dispatch system, and it prompts the telecommunicator. So it streamlines the process and makes it much more efficient, and kind of brings us into this century a little bit, right? With we've got it on the other end with the computer-aided dispatch. This really, really bolsters that ability to streamline the process, one, and second, be able to carve out calls that don't necessarily need a fire truck and an ambulance, going lights and sirens. Currently, we have a one-size-fits-all approach, right? What we want to do is we want to make sure that we have a more tailored response based on what we have on the other end. That is where we get into the 911 triage. And I just referenced that, we make that determination as to whether or not it's lights and sirens or not. Is it emergent? Is it non-emergent? Non-emergent doesn't mean they're not getting anything. It just means they're not going to get a fire truck and an ambulance, right? With, two folks on the ambulance and 3 folks on the fire truck. So they're not going to have, 5 people responding to the call, lights and sirens. It's maybe been carved out for a different response, something that's more tailored to what the need is. And then how do we get that service there? Mobile integrated health. So I talked about how we currently have our mobile integrated health program, and that is the medical based piece. So the mental health base would focus on mental health. Our mobile integrated health manager partners with the behavioral health nurse from UW Health, and then they would be that tailored response. So now you've gone from having a fire truck and an ambulance respond to a call that is behavioral health centered, and you get something that is actually tailored for that call. Now, having said that, there are a couple of things that are extremely important too that do play into it. One is it's rare that you have a call that just kind of fits one discipline, right? So we might have a medical call that also crosses over into a law enforcement call. We might have a law enforcement call that perhaps crosses over into the fire side. You may have a behavioral health call that starts as an EMS call and then is recognized as a behavioral health call, but there's still a medical component, right? So there's all these variables that play into what type of response you're going to get. And that is why the Pro QA piece is so incredibly important to this holistic approach to the mental health response, because that will help us and allow us to carve out and tailor that response. So the mobile integrated health piece, which is again, mobile integrated health manager paired with a UW health behavioral health nurse. They have a holistic approach. Again, connecting people with services. Do prescriptions need to be filled? Do you need to be connected with a counselor? Do you need somebody long-term? Do you already have somebody long-term and you haven't been able to get in? You know, they can sort through that, and there's follow-up until that person gets to where they need to be. When I say follow-up, perhaps that initial response, but then follow-up that may go on for a month. It may go on for 2 weeks. It may go on longer than that until the person is connected with where they need to be connected. And again, they would specialize simply in the mental health and behavioral health piece. The other piece too, that's also, it's very, very critical, is that they work within our healthcare system. So one, they're connected within the healthcare system and have access to all of the services and understanding which services would fit a particular patient or a particular person in a behavioral health crisis. Additionally, they also, and we just talked about this a bit, they would be able to transition into that post-crisis. So it may be, you know, maybe it is a month, maybe it is 6 months, maybe it's a week, maybe it's 2 months, the transition piece into that post-crisis part. And then finally, the whole system also allows referral to outside services, so that we make sure, and this is where, and I know we had some questions the other day, we talked about some of those outside services, things like 988, things like there's different legislation coming through the state that will affect mental health and behavioral health response, being prepared on a local level to address the needs of our community, and then all the rest of that stuff will fit into what we do. And sometimes, you know, that does seem like, well, if the state's saying this and the feds are saying that, you know, that's great. And we will certainly make sure that we are meeting those needs. But what I have found with our response is typically we exceed that. And we don't want this to be any less. We want to make sure we are exceeding any particular needs or criteria or requirements. We want to make sure locally that we are exceeding that. And this program does, will more than exceed meeting the needs of our community. So I thank you for next. There we go. How do we work? Patients are identified through the 911 center, through our utilization data. So that's simply taking a look at the types of runs that we've had, and then referrals from either a healthcare provider or from our frontline personnel. And they would be referred to our mobile integrated health managers. And I have this right here. Currently, we track our patients, or excuse me, currently we extract the information on our behavioral health patients through our reporting system. So what that means is we respond to a call. There has to be documentation of the call. Once that call goes, that documentation of that call goes in the system, we now go in by hand. We have a person that goes in daily and checks for any type of call that has a behavioral health component or behavioral health adjacent. So somebody maybe that is complaining of tightness in their chest pain, and I'm out of my anxiety meds. I don't have my, I wasn't able to fill my meds. I'm feeling very anxious. So there's two components. We just talked about that a moment ago, right? It doesn't often just fall in one particular line. So you've got a medical component as well as a behavioral health component, right? So that's what this is meant to signify. We have somebody that goes through here on a daily basis, and on Mondays that go through 2 days worth, right? If they do it from over the weekend, pull out all of those calls. and we take a look at those. One thing that our software will do that we just talked about, ProQA, that will allow us to pull that information out on the front end because it is integrated with our computer aided dispatch. And that will allow us to take a look at those incidents and that response on the front end. So we will actually get a very, very clear picture of just exactly what the needs are in terms of behavioral health response in our community. So in addition to pulling our information from on the back end after our reporting, our mobile integrated health managers respond with the behavioral health nurse, and they provide scheduled visits, drop-ins, and then incident response when requested. We'll go back to what I had said about we do a one-size-fits-all approach, right? Right now we have a fire truck and an ambulance. They respond to medical calls. So all calls that are not fire, not coded as a lift assist, not law enforcement, are coded medical. So we don't have a breakdown within that medical umbrella. That's what we are going to do with the ProQA software. It will give us a breakdown within that medical umbrella, so we can then carve out, okay, this is simply a behavioral health call, and not simply, but it doesn't need a fire truck and an ambulance. That may even in fact make the situation worse, right? So we want to be able to carve that out, and that's what this will allow us to do. So currently though, we still have a need, right? So when it is identified on scene that we have somebody, then we can call for our mobile integrated health response. And so they will then respond to the call. In addition to that, we can refer them in as well. Any questions so far before I go to the next slide? Because I think the next slide is where we have all our breakdown of our calls. Yeah, you remember.
Me, I do have a quick question. Given that I've been around for so long, and I worked with Bob Burtis for many years,
yes.
Because from my end, we were trying to deal with the, as we labeled, super utilizers of the fire department. So we would meet, and we met for years and never quite solved the problem. But eventually, you know, that's where UW and Swedes at that time, you know, really came into play in terms of helping triage, and a case manager was hired and stabilized. But my question to you is, when we, you know, worked hard to get a waiver for the ambulance to be able to go directly to the Mulberry Center, I'm just wondering, is that one of your referral connections?
It can be, yes, absolutely. Depending on the need, right? One thing we are finding is that sometimes it is difficult because the resources aren't necessarily available or there isn't room. But we do have that as, for sure, as a referral and as an option, and we do utilize that currently when it is available. So, yes.
So is that a problem for you, that the availability is not free? The lack of availability, is that the problem?
It's simply their capacity. So at times it can be problematic for us, yes.
Okay.
So, but we are working on alternatives to that too, which is separate from this, but would integrate nicely into this. But that's a little bit exciting, but a little bit complicated. We just want to make sure that when we have the need, we have,
Right, well,
yeah,
that was the whole design of
for
that
sure.
triage, because they have all the, you know, the resources to do the assessment and, yeah. So I'm just curious how that connection is going. Okay.
And we, like I said, we do use it. It just isn't there. Available, or I shouldn't say it isn't always available. It is available, but the capacity isn't always there.
Okay.
Any other?
Chief
questions?
Echo, I have one, and I might have missed this. You said you had 2 nurses or 2 staff people per shift. What was that? Did I misinterpret that?
So we have, so our current mobile integrated health program, which is the medical, not the behavioral health, we have 2 on staff. So they work Monday through Friday. And their hours are tailored around the hours of services that are offered or would be offered, right? Doctor's offices, clinics. So those hours are designed to accommodate that particular schedule, because most of the time when they're working with those folks, it's to get them into physicians or get them to a resource or to a pharmacy. So that's the mobile integrated health. The behavioral health side, 2 additional staff on staff that would be designated for behavioral health, and they partner with behavioral health nurse from Swedes.
Okay.
So 2 that focus on behavioral health partnered with 2 behavioral health nurses.
Okay.
And that would strictly be, or that strictly is their focus.
I'll make sure I have works.
So I thought that there was some law enforcement connection amongst all of this. How, I don't see any.
That's a different program.
Oh, it's,
There's
all right,
no
so
law-
you're
yeah,
just,
there's no
okay,
law
so this is,
enforcement, yeah.
oh,
And I think in it, well, can I have you go to the next slide? Because I think I've got my next one is. Yes, okay. So maybe this will, because it is a very, there are a lot of layers, right, to the program. So on the left side of the screen, we have what our typical response model currently looks like, right? A call comes in at the 911 center, and then it's either, designated as a law enforcement, or what is not law enforcement goes to the fire department, right? So if there's not a law enforcement call, if it's a fire, if it's a medical, if it's a cat in a tree, everything else comes to the fire department. So you go down those 2 branches currently, and I've referred to it as our one size fits all. You get a fire truck and an ambulance on that response. Now, obviously that's tailored. If there's a structure fire, you would get more. If it's a cat in a tree, you would not get an ambulance, but that would be the response. And then currently, if we identify a behavioral health emergent, or not a behavioral health patient in the field, they get referred right into our mobile integrated health program right then. Or they get the referral. And then obviously down the law enforcement side, the law enforcement call comes in, and then the police are dispatched, and then the CCRT, which is the team that I believe you were referring to, would be part of this component here. Okay, so what we want to move to and where we are shifting, and it is an absolute paradigm shift, right? We're shifting to this type of response flow, if you will. It's more tailored. So call comes in at the public safety answering point. And at that point, we say, okay, is this an emergency? Do they need emergency services, or do they need a service? They just don't need it with lights and sirens, right? They need something different, maybe something a little more tailored. So we take a look at that. And there's a police component, there's a law enforcement component. What did we talk about earlier? That most often it'll overlap, right? So you may have a police that's identified as some type of behavioral health. So then you connect back in with your medical. Fire is also a component of that, because all of our fire trucks have licensed paramedics on them. So they may not be on an ambulance, but they do have licensed paramedics and can get there and deliver life-saving medications, life-saving treatments. And you may triage it. And at the end of the day, there is some follow-up or referral into a program. So you can have all of these components coming in at your public safety answering point. So what we want to be able to do is, with our software, the Pro QA, the call comes in, and if you could go to the next slide, I think I can walk you guys through a scenario here. Yes, so give me a name.
Nick.
We'll use Nick's name. All right,
Wait,
so no, not Nick's name.
So
So Nick
criminal
called-
side or is this-
So we'll go through a couple of scenarios, and we did this the other day very briefly when we were, when some of you folks were, came to tour the 911 center. So we'll say Michelle calls in at the public safety answering point, and the telecommunicator answers at the other end. And I begin to explain that I'm having some anxiety, I haven't had my medications filled and I need some help, I just need to get connected to get more medication. And so initially, okay, this seems very purely behavioral health, right? So does it get lights and sirens, a fire truck and an ambulance? Nope, it goes the non-emergent route and gets a nurse triaging that call saying, okay, so tell me about your meds. So how long have you been out of your meds? How long have you been having the anxiety? Well, I'm out of my meds because I took the entire bottle about an hour ago. Okay, boom. Now you go right back over here and you're gonna get fire, you're gonna get fire, EMS, MIH, not as they're gonna respond to take care of the overdose piece, but as the behavioral health piece, right? Because the first piece of that is truly the EMS response, right? In that specific scenario. Again, we crossed over between behavioral health as well as a medical emergency, right? So you bounce back up here and then they would dispatch the appropriate resource. But let's say that, as I continue talking with the triage nurse says, okay, Michelle, well, what we can do is we can, connect you with either, when was the last time you had an appointment? Do you have somebody that you're working with? We can, connect you with a psychologist or a psychiatrist. We can connect you with getting your medications refilled. We're also going to refer you, or we're going to have a mobile integrated health manager reach out to you so that we can make sure that you are getting what you need. Because what we want to do, one is we want to address whatever the crisis is, right? Whether it's emergent, non-emergent, but we want to address that, correct? But we also want the follow-up component, which is huge. The follow-up piece is what keeps us from continuously visiting the ED or continuously being admitted to the Center for Mental Health. So that is a critical piece. So yes, that initial response piece is obviously very critical, but equally as critical is that follow-up and that referral piece. So if we work through that, let's say I call in at the public safety answering point and I say, you know what? I'm done, I'm on the bridge, I'm jumping. That clearly goes emergent, and you're going to get your fire for your boat response, you're gonna get EMS for the medical response, you're gonna get law enforcement, and you're also going to get the referral piece for MIH once that person once the emergency has stopped, right? Once they have prevented that person from jumping. So see that there are behavioral health responses, but they happen at varying degrees, right? So that's what we want to be able to do is one, we want to be able to identify what the need is. We want to also be able to, as we start to go maybe down that non-emergent path, be able to get them what they need if we, are able to uncover that there's something else there and we need to get them a service. So it's really meant to be a bit interchangeable, if you will, between emergent and non-emergent, but this all happens very, very, very quickly. I know it sounds like you're going through this whole flow chart, but this is just meant to kind of help explain the process, and there's a lot there, but it's tailored. This is what we want to provide for our community. We don't want to continue with just a one size fits all, right? So we do want to make sure that we are tailoring this. And if you could go to the next slide for me. So a couple of goals, just a few, right? We want to break the cycle. We just talked about that. We want to break the cycle. We want to stop or reduce, profoundly reduce the visits to the ED and the visits to the Centers for Mental Health. We want patient-centered care. We want it to be focused on the patient and tailored to their needs. And the 6-month pilot program, and now I talked about that very early on. So if you can go to the next slide. Okay, so the pilot program ran for 6 months from October of 20 to April of 21. We had 20 patients that were assigned to the program. And we saw between a 70 and 90% decrease in visits to the ED, as well as visits to the Centers for Mental Health with UW Health. So that was pretty significant. If you look, 20 patients generated roughly 145 visits or 45 incidents, 145 incidents from 20 patients. That's a lot. So before mobile integrated health, and the blue represents ED visits. The orange represents admissions to the Centers for Mental Health. After mobile integrated health intervention, we have reduced that from 145 to just over 40. And then the admissions to the Centers for Mental Health down to 1. So clearly, that meant mobile integrated health intervention truly did have a pretty profound impact in reducing the visits to the ED and admissions to Center for Mental Health. Questions on that? So another piece that we found as well, so that was 2020. So, and I did talk a little bit how it's, we have to, essentially, we manually pull our information on the back end. After the report has been written, we pull information out. So in 2021, we had roughly 2,600 either behavioral health or behavioral health adjacent. So again, a medical component to that call. Throughout the year. Of that 2,600, roughly just under 600 were pure behavioral health responses or purely behavioral health calls. So, that averages out to a little over a call and a half a day in this particular area. I suspect that number is probably higher. I don't know how much higher as we begin to, extract information through our software on the front end. I think we'll have a clearer picture as to just exactly what that need is in our community. But I'm very excited about the opportunity to truly address something that we've identified as a need in our community and sort of bridge that gap. So one last piece, speaking of gaps, cue next slide, additional training. So as we've been going through the process to get our program up and running, again, we have the software component, right? We have the mobile integrated health managers, the 2 on staff, partnering with UW Health for the 2 behavioral health nurses. In addition to that, we also found that there was, okay, it's going to be time consuming, right? This is a big program. This is a very, very large undertaking, very important undertaking, yet very large. What do we do in the meantime? Right? Because now we've identified, okay, we've got, we have this need. What do we do in the meantime? So in the meantime, part of the training for the new ProQA software surrounding Protocol 41, which is the protocol that deals with behavioral health, does have a training component for telecommunicators. They do 4 hours of virtual, 8 hours of in-person in class training just specific to behavioral health emergencies. So that's fantastic. But what about when we respond? What about that one size fits all stuff that we still have going on that we're looking to tailor, but we're not there yet? What do we do in the interim? So we were able to find 2 different programs. One is a certified program, behavioral health, mental health first aid. And in addition to that, we've also got a program that we got from Joliet. I was trying to think, Joliet or Elgin, Joliet Fire Department, and that is additional training that we will be rolling out by the end of the year. We'll have the whole department trained on that. So at least until we have this program completely up and running, we'll still have everybody on the department trained in some level of behavioral health response. So it's been good for us as well, right? Because, in addition to identifying this need in the community, we've also identified a need in our training and a need for our personnel. So we've adapted to that, and kind of hit the ground running, like, we have this gap, we need to find something to address it. So I believe that takes us to questions. Yeah. Oh,
I have a comment. I don't have a question.
okay, okay.
No, as a board, I know that we've had many conversations about the investment from the programs that we fund. And we look for champions in each program, because without a champion, they die, or they're fragmented. And to have you as the head of the department here today and leading this, and obviously you are so well versed in this. I thank you very much from our perspective. It's because we need you to do this and to see it through, because it's the top on down that makes it successful. That's been our challenge, but no, I'm sincere about it. We are really desperate to find that person in every program that we have. And our next big champ is connecting the system of care that we, are strategically funding to, help fill the gaps like you are in your own department, but we're trying to do a community wide with our, our strategy of funding. So hopefully, you will be the model that we're looking for.
Well, I would be remiss if I didn't give a shout out to our EMS coordinator, Brian Park. Brian Park has put a lot of, done a lot of, and I think some of you have communicated directly with him at times. And he has just done a phenomenal job in, anytime we find something that, okay, maybe we need to look in this direction, he is on it. And he's working through trying to come up with, a solution or a different route. So he truly has, been very integral to this venture, as well as you mentioned Bob Bertez, right? So yeah, we're excited. And then maybe Trent Brass. I don't know if you guys remember dealing with Trent. So we truly have had just this gifted group of individuals that have really, really wanted to move this forward. So it's very exciting to have that commitment, from the group.
Chief Panko, I do have a question. First, what Mary Ann said, okay? And second, and maybe I missed this in your presentation. I heard you say that the 2 staff and the 2 nurses, okay? Monday through Friday, is that how that's working? What is it, 24/7?
So currently it would be Monday through Friday, which is where we identified the gap, right? Because we need to have something, right?
Yeah.
So until we are able to transition that to a spot where it would be tailored to utilization. So when do we have the calls? That's the big piece, is identifying when do we have the peak times.
See, and that's where I'm coming from. And as I'm understanding this, again, correct me if I'm wrong. Mental health doesn't stop at 5 o'clock at night or 5 o'clock in the afternoon on a Friday. Obviously it continues on 24/7, holidays, weekends, all that. Is that being part of it? Is that integrated in your ways of doing it, right? Think of a better term right now.
So what we're currently doing, we want to know when, right? So we've been pulling information and are trying to zero in on what is that time of day. What are we calling our peak hours? That's what we do for our EMS side of the house. That's what we do for our fire side of the house. So it stands to reason we use the same method for the behavioral health side. And right now, preliminary shows that it's from roughly 8 a.m. in the morning, 8-ish, around there, to about 10 o'clock at night. So we're trying to really kind of, where is that, where do we have the bulk of those calls? Now, does our current schedule match up with that? It does not. But that is, that's the goal that we want to get to, is we want to be able to tailor that mobile integrated response, the behavioral health response, with the, what the needs are of the community, those peak times. That's what we want to go to, but to have that 24-hour response, no, we don't have that in that mobile integrated health position. However, we do have, or will have, that mental health first aid to bridge that gap, right? Because again, that's something we identified as, hey, this is gonna take time. This takes a while to get people trained, to get people hired. On the, on the nurse side, on our mobile integrated health manager side, it takes time. Software, training, telecommunicators, there's all these giant pieces that we're bringing together. So what do we do in the meantime, right? So, 'cause like you said, behavioral health emergencies don't sleep, right? Just like medical emergencies and fire emergencies don't sleep. So what are we doing in the meantime? In the meantime, we are rolling out a training program for all of our personnel so that they will at least be able to address in the first aid manner, in a first response manner, behavioral health emergencies. And so that will be everybody on the department.
Triage center could somehow become more active in that, the Mulberry Triage Center.
And they are. I
worry about that component because that's why we fund them.
And they are,
To be available, for the fire and for the police, to bring these people in at night there, because they can provide everything you're talking about.
correct. And they are. At times though, like I had said, that capacity, they may be full, and there's nothing they can do about that.
But they have the triage and then they have crisis residential. So they should be able to accommodate more people in the triage for evaluation for sure.
For sure.
But, okay, so any other questions? Because we've got to take advantage of our board member that has limited time here, right? To get our action items in. So any other?
Well, the only comment, again, you relieved a lot of anxiety. But when you expressed the dream that we had for this whole thing of saying, we've given enough resources to the community to have the best crisis response system, in our opinion, in the state. So, so to hear you say that, recognize that's satisfying. My other question would be, does Brian Park have someone like him in the police department with worrying about the same things? And do they get together often?
I don't know.
Okay.
I know that we do, I do know, you're referring to the CCRT?
Yeah.
So we do communicate.
This thing, as you're saying, is complicated. And particularly when it crosses over, to even more than that, Lowe's Park and the whole thing. So
Okay.
all we were looking on is, like we talked about, champions that are gonna make this thing fulfilling. And then my only final question, the software, it's in the process of being implemented. What I think was your language. How long will it take to fully integrate this new
software? So there are two parts to the software. I'll do them very quick because I know you've got to, right? So there's two parts to the software. We've already had our onboarding meeting. They were here for a week. So we've already started that process. The training will be taking place over the next few months. And then the first piece, that Pro QA, we're hoping to implement either by the end or just after the first of the year. And then we have to have 93% compliance with that software to go to the next step, which is the step that we're going to get to. That's the step we want, which is that's the triaging piece. And that's called low code. So then beyond that, a minimum of another 3 to 6 months before we would have that. And these are numbers that we got from the software vendor, right? That it takes this long typically for an organization of this size to come to 93% compliance. So that's where we're getting those timeframes from. So, maybe we'll be faster. Maybe we'll be, more in that 3 to 6 months. I'm not sure yet, but that's, roughly how long it'll take to fully implement that.
Thank you.
You are quite.
Thank you so much.
Thanks for having me. I do appreciate
taking
it.
your time. That's a big deal.
I'm gonna pay this.
Graham, would you mind if we go to our action items so that we can get them passed while we have a quorum of board? All right, thank you for your.
We may need a motion to adjust the
Oh,
I'll make the motion to adjust the
okay.
agenda. since I have
And we'll
5
need a
minutes.
second.
Second.
Okay, Kim, the first, all those in favor, please say aye. Opposed, say sign. Okay, so we can adjust our agenda to the action items. The first one being I need a motion for the minutes from our September
So
20
moved.
Second,
to be approved. Okay, we've got a first and a second. Any discussion, any corrections? Hearing none. All those in favor of approval of the minutes from September meeting?
Aye.
Okay, opposed, same sign. Moving on to program year 22-23 special conditions. Jason,
Sure.
do you want to?
Briefly and concisely, the special conditions included a risk management plan that we asked for from Boys and Girls Club. They, are partnering with a mental health service provider, so did not previously had a mental health specific risk plan. They have now adopted that. There's a risk plan for also specifically aimed at crisis response, or I should say crisis screening and response as it relates to the Circle of Change program, where they will have youth working with the dog trainers. And so the question was, if a child is having a crisis in the moment, what would they do? And they came up with a fairly good, in my opinion, crisis plan that was actually in partnership with a mental health provider that we fund, who was willing to offer them some assistance in developing this. Was a great partnership that took place with that. And then thirdly was remedies, renewing lives on their behavioral health program. A new program, we asked them to create a business plan for us that just articulated more clearly the things that were already discussed in the grant. And I think that in reviewing that, I feel pretty confident that it is well aligned with the board's vision for that program.
Yes. Any questions, discussion on that? So I would need a motion for approval of
Motion.
the
Hey, you got it.
hearing.
Second.
Second from Deb. No discussion, questions, hearing none. All those in favor of the program year special conditions for the 3 programs outlined, being Circle of Life and Remedies and
Boys and Girls Club.
Boys and Girls Club. They were all in our packet with details, so obviously we could review that as well. All those in favor, please say aye.
Aye.
Opposed, same sign. Okay, we approved. And then the third and final action item is the fiscal year 2023 work plan.
Yes, so the budget, our budget that we submitted to the county board was approved, I believe, last Thursday. And so now we can formalize our work plan based on that full budget having been approved. There was a draft of this budget that was presented to both this board and the county board along with that of this work plan, along with the budget that was submitted for fiscal year 23. Just to highlight quickly, the 3-year strategic plan update will include a data analysis, a data collection phase, which will include an updated environmental scan and community input survey, and the potential for some specific focus groups of community input focused around populations who may experience the most difficulties or barriers accessing services, to get a little more detailed qualitative information. There will be a data analysis component. Then that will lead to prioritization, which will include a board retreat, which will be open meeting, open to community, but a facilitated time to dig into the data and to establish priorities, which will then be formalized into a written plan. With more time, we'll be able to allow for a public comment period in our written plan before finalizing. On the grants program, based on our budget, if we renew all of our 30 programs in full or up to their 5% potential increase, we could be looking at about 75% of our budget in renewal programs this year. So we have split up the renewals from new applications this year And renewals will have a abbreviated application process, an abbreviated review process, looking at compliance and performance goals and allocation of funds being spent. On new applications, we will get a little more targeted and strategic about remaining gaps that exist rather than being completely open and responsive. We want applications around these specific gaps that still remain. In response to previous questions about should we have an appeal process and understanding that that's not practical, we would like to do an abstract round before receiving full applications to try to mitigate a little bit some of the amount of energy and time that an organization might put into a full application for something that may not be well aligned with the board. So that's just all to say that's the new process. It's all outlined in the work plan, and I will leave it at that.
Nice going. Beautiful.
Okay, so I will need a motion for approval of the fifth. Who moved? Wendy, okay. Second? Tim, thank you. Any discussion? Hearing none, all those that in favor of approval for the fiscal year 2023 work plan, please say aye. Aye. Opposed, same sign. Okay. All action items have been approved today, so we will then flip back to our agenda and ramp on the mental health services and training update. And welcome. You can introduce yourselves if you speak. I'm sorry. Okay, thank you.
Take care.
You can adjust the podium.
I will walk you on one.
Okay.
Bye-bye.
Yes.
Yes, and actually I had to reflect that Tim Neighbors is independent. Thank you very much.
Okay, so thank you for having us. We're from RAM. We're excited to share briefly some of the services and programs that we're offering with the funding we're receiving from the mental health board. If I go out in the community and give a presentation about what RAM does, because we do so many different things, if I go really fast, I can do it in 50 minutes. So we're really trying to hone it into the things that we know you guys want to hear about. So brief introductions. I don't think he needs an introduction because it seems like you all know him. But
For those that don't, I'm the systems and advocacy coordinator.
and I'm Katie Lee. I'm the services director at RAM.
I'm Daisy Fabio, and I'm the mental health advocate at RAM.
Yeah, so Daisy will actually talk about her position. She is a newly funded position this program here and doing some cool things already. You can go to the next slide. So just a brief thing about RAM history. We were founded in 1980 at our Rockford location, which was in the first slide, a picture of our building, which is just across the way. We're the second center for independent living in Illinois, and our services have always been based on the independent living philosophy, which is the belief that people with disabilities have the right to make the choices and steer their own life, just like people without disabilities. Our mission is to build an inclusive community that encourages individuals with disabilities to reach their full potential. You can go to that. So we're just gonna kind of run through 4 kind of categories of services that we are doing through the funding from the mental health board. I'll talk a bit about the youth services we're providing. The board is partially funding some of our services for transition age youth that allow us to either go into classrooms in Winnebago County or work one-on-one with students in Winnebago County to help them plan for their futures, think about their careers, whether they want to go to college or straight into the workforce or trade school, learning how to interview, write resumes, pay bills, all the things that every student needs to know. But we're working hard with a population of students who have a mental health diagnosis because the opportunities for them, unfortunately, have been less than students without those conditions. So we're working with them to try to fill in that gap and help them overcome those disparities we see. But the mental health board also fully funds a youth education advocate who works with youth and their families who are in Winnebago County schools. And these are students either with a mental health diagnosis or a suspected mental health diagnosis who need supportive services to access their education. And that can go from pre-K, like age 3, all the way to age 22. So that was funded in the first program year and was very successful. And this year we're continuing that to grow that program. And then Eric's going to talk a little bit about our community education and awareness.
Yeah, so you guys have in front of you some of the trainings that we provide with the organization. I think when we got the funding, we really looked at the fact that, you know, we really need to educate the community on the impact of mental illness and really, you know, help people to understand that it is a disability. It's something that we as a disability organization are working on. So we're providing any trainings to anyone in the community at no cost. We're going out and doing things like disability awareness, ableism conversation. The chief mentioned that there are some changes happening with laws and how that might affect our system. And we partnered with Access Living out of Chicago to do some trainings on those law changes and what that would look like for members of the disability community. We're also been meeting with them to talk about once things roll out, how do we meet with the city to make sure that everything that's being talked about in the changes of law is being addressed and make sure that we have the best system. You know, I think that it's just, as Katie was saying with our services, 51% of our staff are people with disabilities, right? So when we're going out and doing these trainings, we're talking about people with lived experience, going and talking to people in the community about their experience and helping to educate them on, you know, what do I need? So yes, we all know what we're providing, but what does someone need that's in a crisis or has something going on that, you know, they might need some attention? What are the services and supports that they need from us? And I think we as an organization are looking at that is when we hear something, we're addressing. So even with training, as we're going out and doing training, one of the trainings that we did recently was microaggressions for a local church. And as we were sitting there talking to them, we talked about mental health and how that affects the school to prison pipeline. And our curriculum person drafted a training on the school to prison pipeline addressing mental health so that if someone asks for that, we know how to provide that training. So we're addressing the needs of the community and training whoever needs those things for no cost. And so we've done, you know, remedies have gotten a training. We've just anyone in the community, we're partnering with the Family Peace Center to do some trainings. I think it's just working to eliminate barriers. The other thing that we're doing that I think is really important is we're also operating accessibility assignments. So we're having agencies call us and say, we're providing services to people with mental illness, and we don't know if our services are accessible or inclusive. We're sending staff in, we're talking to them about physical access, we're doing policy with them to make sure that we're thinking about reasonable accommodation requests, how to address those, just kind of working through all of that process. So, Ariane, to your point that we have the best system, everyone communicating. No, throw it to Daisy.
Well, I'm actually next, and then Daisy's like, uh-oh. Ben, and to Eric's point, we're mandated as a Center for Independent Living that 51% of our staffing board have to be people with disabilities. We exceed that on both the staffing board side, and we've been really working to fill our positions funded by the mental health board with individuals with lived experience with mental health diagnosis. Did you have a question real quick before we move on? I thought I saw you raising your hand. Oh, okay. So the mental health board is also funding a marketing campaign that we are in the early stages of kicking off. And this campaign is really about reducing stigma, improving conversations around mental health, letting people know that RAMP is a resource for them, because it's been a common misconception with our name being RAMP that we are for people who may utilize a RAMP or a physical disability, where about 70% of our consumers have some sort of mental health diagnosis, maybe in conjunction with a physical disability or not. And that program is also, or that marketing campaign is also intended to help people connect with us so that we can provide our services, but also connect them with the other partner organizations and the other programs that are happening in the community. And then Daisy here in the new program year, we got funding for a full-time position to provide services to adults. And that is what Daisy's doing. So she's just gonna talk a little bit about what she's been doing in this first quarter.
Yeah, so obviously I work more on a one-on-one basis with individuals who have a mental health diagnoses, along with if they have some sort of other disability, or if it's just mental health diagnoses. And I've built a caseload working with these individuals more on a one-on-one basis to, in a sense, achieve their goals to live independently in the community and to be, you know, in a sense, active community members. And with that, also with the partner agencies, connecting with all these partner agencies that this lovely board funds to make sure that way our services don't intersect. And if they do intersect, there is that communication in regards to if we duplicate services of some sort and making sure we work in conjunction with each other. And obviously we have a lovely partnership with the Family Peace Center. I have hours over there because I approached the lovely Sierra to kind of get to know what the Family Peace Center does. And I quickly realized the correlation between domestic violence and mental illness. And so I approached her and I was like, is it okay if I have some hours at your lovely center? So that way, if you do have a domestic violence survivor and they do need services, at least someone is on staff. And that way your staff is also comfortable getting to know me. So that way, when they do hand off that person to someone, they have a face, they have a name, and there is that connection. So yeah.
And I'll just reiterate, Mary Ann, to your point of having everyone kind of work together. One of Daisy's first goals in her new position was to meet with every single agency that you all fund. So
Yes.
she's making her way to every agency to learn about the programs that they're providing. And then, as she said, the ways that we can collaborate together. So, and I think one of the things that we talked about is once she gets through those meetings, she and I are gonna sit down and kind of come up with a plan of, okay, what are the system gaps that we see and where can we partner with these agencies to eliminate them and, you know, potentially come back and talk to you guys about some of the gaps.
Yeah, and then also, sorry, I didn't mean to cut someone. But also I wasn't familiar with all of the agencies that are funded. And I feel like certain individuals who you say approach RAMP, know us as a disability organization, don't necessarily know of other organizations who might better serve them for that specific need. So my goal with that conversation is to get as much information as possible, because obviously I'm not perfect and I don't know all the resources out there, but I want to be as knowledgeable as possible. So that way I can provide those services and those connections to the people that I serve.
And some of those connections are already happening. Obviously, you all fund NAMI as well, and we work very closely with NAMI. If you look at any of their marketing for Mental Illness Awareness Week, you'll see RAMP as well as part of that. We work with them in the planning phases and are just making sure that our organizations are working as close as possible because we serve the same population. So,
Right.
Yeah, and one other thing that Daisy does in her role, or will start to do more of, that not a lot of other agencies do, but it's very important, sometimes isn't recognized, is that we work a lot with consumers who need help in their homes. Some of these people who call 911 all the time because they may need help getting a can down or fallen. And we work very closely with the Department of Rehab Services and help consumers learn how to get those services, how to advocate for them, because it's a process and it's scary. And we're hoping that in her role, she'll be able to work a lot more with those consumers whose needs are mental health related, because a lot of times they don't pass their assessments through the state because they maybe can physically do a lot of things, and it's helping them learn how to advocate for themselves in those assessments. And they tend to have a lot more luck when we're there supporting them. So that's something we're excited to be able to offer more.
one thing too, so I think to that point, we also, in addition to that, have relationships with leadership at the Department of Human Services. So as those gaps come up that Katie was talking about, we can reach directly out to, you know, the head of the department and say, this is a systems gap that we're seeing. Let's sit down and have a conversation. So not only are we solving it for that one individual who lives here in Winnebago County, but potentially we're looking at a solution statewide that's going to impact everyone.
That's Eric's skill right there. He picks up the phone and calls every legislator knowing Deborah's here.
So again, we do so many things that weave into the funding you're providing us and the services Daisy's providing and our youth education advocates are providing. But that would be a really long session here, and I know we only have a limited amount of time, but just a few quick statistics I want to share that in the last program year, we ended the year having served 101 individuals throughout the whole year. This first quarter of the new program year, we served 123 people. And that is a 40% increase from quarter one of last year. So we expect that number of 101 served last year to be greatly increased because we have another full-time position now serving the adult side, where last year was much more youth focused. So we're excited about that too, to see where that goes.
Yeah, great.
So next slide was a big question mark, I believe. So any questions for us?
Would you mind sharing a little bit about the youth program and what you were doing with kids last year?
Yeah, and we're continuing to do it this year. So education and advocacy services are typically provided to the parents of the child. So kids with disabilities, I have a child with a disability who's now in 6th grade and he has mental health diagnosis and autism. And so I know firsthand how that is. It's very hard to navigate the system in school, and a lot of kids fall through the cracks and don't get the support they need. And parents, when they're in a room with 10 professionals, don't always know what to say and what their rights are. So we work with them to understand that, to maybe understand their options, other ideas, things we've seen work for other students. And then we can even attend meetings with them and like sit by them and help ask those questions when they're maybe freezing up or feeling intimidated, so that their children can either get the services they need in school or be placed in a program where the supports are available to them.
Thank
And that's offered for free because we get this funding.
Thank you.
We used to get state funding for that, but the funding changed a bit. So
That's an essential service
it really is.
navigate the system.
Yeah. For my own self, when my son was exhibiting a need for services in school, I had no idea what to do. It was before, at the beginning of my time at RAM, so I know what it's like to be on the one side of it and then on the other.
And you're most helpful that way.
Yeah.
Daisy, thanks for calling us lovely. You needed
Yep,
that.
thank you for your presentation.
Thank you for your support. And we provided, like Eric said, the big sheet is some of the trainings we do. You'll see there's a price on there, but again, we're able to do a certain number of those for free in the community because of the funding. We, of course, will prioritize those for other partner agencies or agencies that are working with the population that we're all trying to support. Then we have our kind of general rack card and information about an upcoming event. We have our annual luncheon. So feel free to take a look at those and share them.
Thank you.
Thank you.
All right, thank you.
We do appreciate it.
Nice meeting you too.
And then here's your extra.
Oh.
Thank you. Thank you.
Thanks so much. Yeah, so that's where I'm headed back. We will just review the monthly activity report, if Jason has any highlights.
Yeah, I do have a couple of things I'd like to highlight this month.
Thank you again.
Thank
Legal
you.
eyes.
Some of it's noted on this report and some of it has actually happened more recently. And so I'd like to update you on a few things that we've already started to move forward with on systems coordination. When the Youth Mental Health System of Care Collaborative came and presented to us, they talked about a referral system called Iris that they were working on implementing. They have moved forward with that and will be looking to now implement that community-wide with a number of mental health providers. They are looking for somebody that's a little more neutral and not a direct service provider to be the data administrator that can review the data that essentially is going to show where the referral gaps are, the amount of time it takes from referral to actual appointment. And they reached out to us to see if we would want to play that role. And I believe that role is well suited for us. We're going to listen to the next step and understand if that, what that would require in any type of formal agreement, and you can bring that to the board if there is a formal agreement. But I think that data, which will be community-wide data, is going to be very complementary to the type of data that we're using to inform our 3-year planning and our evaluation services. So I wanted to highlight that. Secondly, is that yeah, go ahead.
Was there a fee or any exchange?
No, there's
Nothing.
no monetary exchange. They're not
Okay,
asking
alright.
for money. They have this
All right,
funded through their other grants.
all right.
So there's
Very
no obligation in that way.
Yeah, it's University of Illinois, funding.
Okay, very good.
The workforce board, so one of the elements and strategies within our systems coordination plan is workforce development, addressing the sector employment crisis essentially for mental health workforce. The workforce board has a pathways committee that previously has addressed things like engineering and middle skills gap. They are going to form a mental health subcommittee under that committee that will focus on career pathways and workforce development specifically for mental health. They've invited me to meet with that committee on Tuesday to talk to them a little bit about what we're seeing on our end and some of the struggles organizations are having filling their funded positions. And then we will see how they might move forward from that and what our level of partnership might be in that. Again, no monetary ask on that, something that they is already in their wheelhouse to do. And then on communications and I guess general PR, highlight that Chelsea has scheduled the first communications work group meeting for October. There's actually 3 of those meetings going to be set for October, November, and December to get those funded agencies that have marketing and communications departments to start working together on a system-wide communication strategy to build awareness around the funded programs from the half-cent sales tax. And kind of adjacent to that is that RAMP has nominated the Mental Health Board for an advocacy award. There's no monetary award with that. There's no money coming with it, so there's no exchange of funds. I did vet that with legal and also with ACMI through the network of other mental health boards to see what precedent some of those other agencies that have been more well established have. And there is no legal reason that we cannot do that, nor is there any mental health boards that have policies that disallow them from accepting non-monetary awards from funded agencies. So they have given us 2 tickets for that. Should we receive that award? And then otherwise, if anyone else wanted to attend, I believe they passed out the flyer there. So you could purchase a ticket to attend it if you would like.
If I may, looking at this, and my first thought was, how come we're not all attending this? The table's $400, and it's, there's 8 of us on the board, or we can go 10. I think 10 for a table of 10 is 400. That would be I think it's a good PR thing for us. I mean, it's one thing to wear the merchandise, which is wonderful, but to actually be there, because again, nobody knows who the faces are.
However, here's the thing about that. It would be setting precedents. If we
Yeah,
did
I
anything.
understand.
And we would be going to 30 fundraisers because they all have them.
As long as they provide a good, surf and turf, I'm there.
But Jerry, it depends on the agency. I mean, Rosecrans, you're talking about a $1,500 ticket.
Yeah,
They
I
don't
get it, you're
have,
right.
so I worry about whether or not that's a precedent we should start. This, I had Jason, talk to, the other mental health centers or boards to find out if there was any precedents there, and, you know, legally, this is a fine thing to do.
I think it's a good precedent to do, because all public agencies do it, you know, it's part of PR, part of, you know, public relations. Everybody don't have to attend, but,
Right,
you know, even like the county events, we go to all these little events too. The county buys tickets for them, the city buys tickets for them, and we're another part district buy
right,
tickets for
right,
them. So
right. You're
it's part of the stuff that we have to do to show support to the community, to the agencies.
But I think it would be good that, you know, that each fundraiser that comes along, if the mental health board is invited, that one person or two people, you know, if they so determine that's a good date and they can go, I see nothing to that, but
Yeah, so that's how to do all of it.
Well, I just thought that, you know, when I was looking at this thinking, you know, wouldn't be a bad idea if we all went, but I understand, and you're right, it is what you were saying there, sometimes they buy tickets, just go. Who can go? Here's tickets,
Right,
go, and you can
yes.
go.
and it doesn't have to be the whole board, just.
Right,
one is good,
exactly.
As long as it's a representative.
yeah, exactly.
And out of 30 different organizations, let's see. You have 20, I'll give 50, 30, we're done.
And you're going,
Well, so what I was gonna say is that they have offered us two, so we don't have to have the conversation necessarily today about buying tickets to events, because they've offered us 2 free tickets to this event. But perhaps in a future board meeting, should that, you know, be a conversation, we could add that to the agenda. So, yeah, I have not confirmed who specifically is attending, so I suppose if you'd like, I am able to attend, absolutely, I have the time called on my calendar, so. Just, I guess, let me know if Mary Ann or you, I don't know. if you're-
what date is it?
It's a Thursday.
20th Thursday.
Okay, where did I put that thing?
Not
October,
this one, that's kind of board meeting night, so I wouldn't be.
Yeah.
flyer.
oh,
The flyer.
here it is.
What?
I have a dentist.
Thursday,
Oh, that's-
October 20th. And so that will be coming up in 2 weeks or a week.
So we can coordinate
Yeah.
schedules of who's able to
Let me-
attend, and
Yeah.
Check mine.
I think you're welcome to, you know, purchase a ticket and attend all.
When is the communication meeting? First one, Chelsea, you're gonna do when?
October 18th.
Yeah, that's the 18th.
And
Is
Linda,
that a Zoom or in person?
It's a hybrid, so Linda will be in attendance, and then we have reached out to a couple organizations. So we are offering a hybrid option to, get the most amount of people involved. So, we recognize that in person is great for more in-depth and collaboration, but we didn't want to limit it due to schedule constraints. So it is preferred in person, and then remote option.
Okay. Right.
Okay.
Is anybody going to the nominee event tomorrow?
yes, so I've been invited to attend and to speak, do a 5-minute speech on the mental health board as an
What
update.
time is that?
It's on Friday at noon.
Oh,
And that one is
Mental health rally.
the rally,
Yeah.
yeah. I usually,
Yeah.
It's at the Nordlock.
Right across the park.
So again, if any board members are going to attend and would like to,
It's Friday?
Come on tomorrow, Thursday.
Friday,
Friday
Right.
usually is on.
Yeah, that's right.
Sure.
At noon.
it's Friday at noon. with the North-
Okay, all right,
I'm looking at it wrong, yeah.
yeah. Yeah, I was gonna look at.
So not only were we invited to give a 5-minute update At the rally, also, we were able to give our handouts for the funded programs. They're putting together a packet this year, a folder that people can have with different agency information. So we were able to get our program handouts in there. They're passing out 125 of those.
That's wonderful.
Yeah.
Very helpful. Okay, moving on, discussion items. I had none on the agenda. And for that matter, the next agenda item, other matters, I had nothing.
I have just something.
Very good.
Indulge me, please, for about a minute or two.
Yes,
I had talked with Ed and his people about doing that little PSA, less than 20 seconds, so they're willing to do it. Just how many here are willing to do it? You know, like Mary Ann, I want you to talk about therapy, depression, therapy, you being the therapist for those you know. I thought I can give you an idea, and then you can just run with it unless you have your own. Dick, you're never too old to exercise. And I thought, how you know, take a walk, do whatever it is.
he plays tennis.
Yeah, see, and I just think, and I thought, Dick, you'd be perfect for that,
Okay.
okay? Tim? I know you're gonna look at me here, I don't want to.
All right, as long as you write the script.
All right, well, here it is, breathing, you're being in the business of that, you know, how to deal with people who are, you know, experiencing over the holidays or experiencing the first holiday without a loved one, how would you handle it, you know, and so forth. And I thought Wendy could talk about how the law, you know, if something's going on and you're depressed because you're having a legal action, get a hold of a good lawyer who's gonna represent you well. I talked to Bill the other day and I said, I'd like to see him talk about pharmacology or the medication management. Talk to your therapist if you don't think it's working to help alleviate the depression you might be having. You know, so he thought that was good. So I'm just kind of going through different things. But if everybody's interested in doing it, I thought it'd be a good one. And I thought, you know, and it starts in November. We would do, you know, a couple of them a week, 3 a week or whatever, till we get up to Thanksgiving, and then we could run them over and put them on our website, you know. And put and share them other places. You know, we keep talking about how we don't get the word out enough, and I thought that would.
Well, what are you gonna talk about?
I'm glad you asked. Humor. What else? I know, I'm looking for that little red rubber nose I put on my face here. But you know, humor and how you can laugh at, you know, I always think it's the best medicine. So anyways, think about it, ladies and gentlemen, if you really want to do it, dopamine, right? But if you really want to do it, I would love it if you would.
When is the deadline to let you know about this?
You know, there really is no deadline per se, but I need to talk to the gentleman who's going to do the filming. I want to do it in one afternoon. You know, because you can take 2 or 3 takes, like I said, 15, 20 seconds. Hi, my name is Mary Ann Body. I'm from the Winnebago County Community Mental Health Board. I'm here to talk to you a little bit about, you know, your therapy. If you're depression in therapy, listen to your therapist, take the cues from them, ask questions, and get better at what you do. That may help alleviate your depression. How's that sound?
You did good.
But I'm just saying, just to me, those are just a quick little anecdote to throw out
Well,
there.
if you give us the time that
I will.
we need
Yes,
to
ma'am.
let you know, that would be helpful.
Yes, ma'am. I will make sure. I wanted to wait till I talked to all of you before I made that decision because I want to see who doesn't want to do it. Linda, volunteering. You know, working with who did she work for? United Way, thank you. United Way all those years. You know, volunteering during the holiday season. You know,
It's an issue.
never does one stand so tall when they stoop down to help someone else. Yeah,
All righty, sounds good. If you get it back.
I will
with
get you the
details,
information.
that'd be
I
helpful.
wanted to wait till I could see who wanted to do it, and if you're not comfortable with it, that's fine. I get it.
Okay, perfect, thank you.
Mhm.
So I need a motion for,
Make a motion to adjourn.
okay, second, we need a second.
So I said,
Okay, all in favor, please say aye.
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 Opposed, same sign. Okay, here we go.